cancer care is a team sport. And Dr. Kaul has joined me on that mission to educate gastroenterologists on the lingo of cancer care and how we become an essential part of the multidisciplinary team.
It's a nice way to kind of review what's the latest on the topic and also get tips and caveats and pearls from the experts related to clinical practice that will be of value, hopefully, on a daily basis. So all in all, a tremendous value proposition and very excited to be part of it.
I'm very pleased to introduce Dr. Vivek Kaul, the Siegel Watson Professor of Medicine at the Center for Advanced Therapeutic Endoscopy at the University of Rochester Medical Center, and Dr. Toufic Kachaamy, who's the Enterprise Clinical Leader and Interventional Program Specialist at the Cancer Treatment Centers of America, part of City of Hope. They will be speaking this morning on liquid nitrogen cryotherapy for foregut cancer. They'll be providing a review of the evidence, guidelines, and clinical applications on this area. Thank you very much for your time today. Please.
Good morning. Thanks, Whitney, and DDW and Status team for inviting me to speak on this topic. Can you guys hear me okay? All right. So this roughly 30-minute didactic is divided into two parts. The first part covers dysplastic Barrett's and early esophageal cancer, and the second part will deal with more invasive cancer with Dr. Kachaamy, and then we'll take questions. So my charge is to speak about cryotherapy for dysplastic Barrett's and early esophageal neoplasia. My first few slides will talk about the background for Barrett's esophagus and esophageal eradication or endotherapy for that disease. As you can see here on the left side of the slide is non-dysplastic Barrett's, indefinite for dysplasia, and low-grade dysplasia. The vast majority of patients will carry on with their life with non-dysplastic Barrett's, and currently the guidelines do not recommend endoscopic therapy for that. Indefinite dysplasia needs follow-up as per the guidelines. The typical recommendation is to go back and rebiopsy in the next 6 to 12 months and control the inflammation. Low-grade dysplasia is somewhat controversial because the surveillance guidelines suggest surveillance, and certain cases may be selected for therapy. We can get into that in the Q&A session. There is no debate that for high-grade dysplasia and for early esophageal cancer, endoscopic therapy is the preferred standard of care. And then over to the right is invasive carcinoma, which Dr. Kachaamy will reflect upon in the second session, and there are some newer paradigms emerging for that. When you look at surveillance versus treatment, extremely on the left side is non-dysplastic Barrett's, which I referred to earlier. In the middle is high-grade dysplasia and intramucosal cancer, and on the right is invasive cancer. So surveillance is recommended for the non-dysplastic patient, and endoscopic therapy is the preferred option for the middle cohort of patients. But for the patients on the right with invasive disease, up until now, surgery and chemoradiation, which we call it definitive chemoradiation, have been the two mainstay options. But now another option is emerging, which is combining chemoradiation or chemotherapy with endoscopic therapy with cryotherapy. And you'll hear a little bit more about it in the second half. It's important to review the basic principles of endoscopic therapy, which are listed here. Number one, resection of all visible lesions with EMR and or ESD. Number two, ablation of residual dysplastic tissue using any of the several modalities available that are listed here: RFA, cryoablation, APC, hybrid APC, multipolar electrocoagulation, and currently under investigation, the powered endoscopic debridement device known as the endorotor. On the right side is a box that tells you what the outcome should be and what the goals of endoscopic eradication therapy should be. Complete eradication of dysplasia, and in my personal favorite is the complete eradication of intestinal metaplasia, which should be the high bar that we need to meet. An important caveat also here to note is that post-endoscopic ablation surveillance is really critical. It has to be done meticulously at timed intervals, and as of today, the guidance is to continue this surveillance indefinitely, because even at 5 years, up to 30% of patients will have recurrence, and that's a topic for another day, but that's to be kept in mind. So surveillance post-ablation doesn't stop as of today. This slide is important and doesn't get talked about much. This is the NCCN Guidelines, and if you look at the red box here, it refers to the management of what is really high-grade dysplasia and early esophageal cancer as per the NCCN Guidelines. Endoscopic therapy is preferred for dysplasia and T1A cancers. Esophagectomy is an option theoretically, but at least in the mainland United States and many, many parts of the developed world, esophagectomy is now currently not offered for dysplasia and early esophageal cancer. Now for the T1B cases, esophagectomy is still the standard of care, although some select cases can be managed with endoscopic therapy. This is a short video clip showing how visible lesions are resected with band EMR. This is an apparatus that is loaded onto the standard gastroscope. The dysplastic tissue is sucked into this barrel, and then a rubber band is deployed, and then you can take a dedicated snare to resect the pseudopolyp either above the band or below the band, and both are safe, leaving an intact muscle layer at the bottom, which you will see in a second here. This is a highly effective, efficient, and safe modality to resect neoplastic tissue, and you can see the visible muscle layer. Without jinxing myself and my future practice, I should say that it's very difficult to perforate the esophagus with this apparatus. A brief word about endoscopic submucosal dissection. The era of ESD for Barrett's and adenocarcinoma of the esophagus has arrived, thanks to Peter Dragunov and Dennis Yang, who've written a couple of the papers on this. ESD allows for en-bloc resection of visible lesions, typically lesions that are greater than 2 centimeters in size. It does require more effort and expertise and time. It is a skill that is acquired over a length of time and by training with appropriate mentors. The follow-up for post-ESD suggests that recurrence rates are in the 0.2% range and that complication rates are slightly higher compared to EMR. And this is the paper that was done. It's a relatively small number of patients where we saw EMR versus ESD. The R0 resection rates, which is complete resection of the tumor in one go, were much higher with ESD, as expected, compared to multiband mucosectomy. However, the adverse event rates were also higher, although did not achieve statistical significance because of probably the small number of patients. So the conclusion of this study was that both EMR and ESD are effective for endoscopic therapy of raised focal lesions, but that ESD may have slightly higher complication rates and stricture rates compared to EMR, which is understandable. The next slide talks about a pivotal point in endoscopic therapy, which happened in the mid-2000s, which was the introduction and establishment of RFA as the first real, widely adopted endoscopic ablation modality. And these are the pivotal trials that are listed here with CED and CEIM rates that established the benchmark for where we need to be with endoscopic therapy. So RFA remains as an established, effective modality, which is in wide use, and this is an important slide to reflect on. And then subsequent to the establishment of RFA came along cryotherapy. And these are the two cryotherapy-based platforms currently commercially available. The nitrous oxide C2 cryoballoon focal ablation system uses nitrous oxide at minus 85 degrees centigrade. It's an 8 to 12 second cycle depending on what you're treating. It's one application per treatment, and then you move around with the balloon. And the FDA approval for this device is that it's a cryosurgical tool specifically designed for endoscopic ablation of dysplastic Barrets. Now, liquid nitrogen spray cryotherapy with the TrueFreeze device is liquid nitrogen at minus 196 degrees centigrade. That's about 5 times colder than the North Pole. Each cycle typically right now is 30 seconds, and we apply 2 applications per site for flat Barrets, and then you can escalate to 3, 4, 5, 6, and Dr. Kachaamy does about 18 applications, sometimes. No, I'm just kidding. The 510K approval for this device is very broad. It's a cryosurgical tool to ablate benign and malignant lesions, period. And that speaks to what you will be hearing in the second part of this presentation with Dr. Kachaamy. So here's basically a short video clip showing spray cryotherapy, which is a standard gastroscope with a cap. We apply the spray from a distance. It's a non-contact application. And it, of course, delivers liquid nitrogen at a very, very low temperature. It's very well tolerated, it's very safe, and highly effective, as the data will show in the next few slides. The indications for spray cryotherapy are listed here. Now, apart from the standard primary indications of treating flat dysplastic Barrett's and post-EMR ESD cancer for residual dysplasia, there are some other indications that emerge in clinical practice, such as treating the dilated esophagus where balloon RFA is difficult, treating patients with difficult upper esophageal anatomy, patients who have a very thickened nodular Barrett's, which may or may not be amenable to endoscopic resection, and where such a widespread resection is required, where the stricture rates are very high, and it's physically, technically not even possible. So those are some of the unique niche applications in the primary scenario. For secondary therapy, and these are terminologies that the oncologists use, primary therapy, secondary therapy, salvage therapy. For secondary therapy, it has a huge application in the realm of refractory Barrett's, which is Barrett's that has been treated by any of the modalities, including EMR, and has now had 3 or 4. The studies usually use 3 applications or 3 sessions, and then there is residual dysplasia or neoplasia despite 3 to 4 sessions that is now classified as dysplastic refractory Barrett's, and cryotherapy has really emerged as a very solid tool for it, as I'll show you in the subsequent slides. And for salvage therapy, which will be mostly in the domain for Dr. Kachaamy's talk, is for treatment of invasive cancer and also for palliation of cancer, which he'll reflect upon. This is the summary of about a decade of data on spray cryotherapy, which is listed here. And if you see, the first papers were out in the 2010 domain and up to 2020 with a recent meta-analysis that we published. So the CED and CEIM rates approximate those that were in the pivotal trials with RFA, and in many cases they have exceeded those as well. So if you look at this, the last study here, which is the largest number of patients, including all the spray cryotherapy applications, 400 patients, a very high quality systematic review and meta-analysis that we published, the numbers speak for themselves, and the long-term follow-up also ensures a degree of confidence in the robustness of the treatment. So this is an important slide that summarizes where we are roughly 15 years, 10 to 15 years after the commercialization of spray cryotherapy for dysplastic Barrett's. And for early esophageal cancer, these 2 studies again state the story very well. So we have a study from 2017 that looks at T1A and some T1B cancers, where you achieve very high complete response rates after endoscopic resection. Of course, for T2 disease, the intent is palliation, so that number doesn't count for the typical dysplasia, early neoplasia discussion. This is a study we did with Harvard, with Arvind Trindade and Doug Pleskow, looking at early esophageal cancer, post-resection, and then application of cryotherapy, and the numbers in a highly enriched population speak for themselves in the 70 to 85% range. This is our own long-term experience at our center, almost 11 years of work with nearly 200 procedures, a very highly enriched population of high-grade dysplasia and early esophageal cancer. And you can see here some of the highest reported rates of dysplasia and metaplasia eradication came from this study. A CED of 98.1% is not published in any other paper. And this was a spray cryotherapy-based platform that we used. And a lot of these patients, if you see, fully a third of these were RFA failures. This was a very difficult population, nearly 70% EMR rate. So that means 2 out of 3, or maybe 3 out of 4 patients had EMR done. And you know what happens when you do EMRs, you find cancer. So this is a highly enriched population, and these are the numbers. And this is over 11 years with a mean follow-up of 5 years. So this is very robust data with spray cryotherapy at the crux of it. Now, this is real-world data. This is with Nick Shaheen, the U.S. National Multi-Center Registry, which is still unpublished in manuscript form, but this is the pre-COVID last DDW oral presentation. 15 centers, purely spray cryotherapy, all comers, real world, and you're looking at numbers that are pretty much in the real world scenario very, very acceptable, with a 65% CEIM and a nearly 90% dysplasia eradication rate. This paper will be published. There's some 5-year follow-up data that is being collected, but we'll see when that comes out. Now, I mentioned refractory Barrett's, which is a patient who's had all kinds of endoscopic therapy done to them. In clinical practice, usually it's a median of about 7 to 10 procedures that they've had all over the place for years, and then they are sent to us for cryotherapy management. And these are the numbers. When patients come, when everything else has failed, cryotherapy delivers 70 to 80% success rates for dysplasia, and nearly half of them are rid of their metaplasia. There's no other technology that can actually do that right now, and this is important for us to know. So refractory BE is, again I mentioned, is that BE that is not amenable to treatment with established modalities outside of cryotherapy, and is a very typical referral patient that comes to high volume cryotherapy centers. And this is an example of a patient who's had multiple applications of ablation. There is still some residual Barrets, as you can see in this video. And this is a perfect case for application for spray cryotherapy, as you can see here. And the numbers are what they are, and we can almost guarantee that dysplasia will be eradicated. It may take a few more sessions to eradicate intestinal metaplasia, but that's certainly achievable in the vast majority of patients. Now, this is the same patient who comes in years later, and this is the high-definition white light view, and this is the narrow band view of a patient who had a number of procedures coming in, and this is just a typical scenario, and this has already been published in many fora. One specific aspect of spray cryotherapy that I wanted to highlight is post-procedure chest pain, which is significantly lower compared to RFA or even compared to other thermal modalities. And this is a note I just got before I came to DDW. This is from a patient who has recurrent dysplasia after esophagectomy, which was done years ago. So I was treating him with spray cryotherapy, and we got tremendous success. He had minimal intestinal metaplasia in 1 or 2 spots at the anastomosis. So I decided to treat it with APC because it's much easier, it's faster, I thought it would be easier on the patient. And this is the MyChart message that I got from this patient. Thanks so much for taking the time to show me the APC treatment before my procedure yesterday, because we went through the videos and everything. I am sore today, more sore than after cryoablation, but manageable. It amazes me the treatment options you utilize. This is an actual message from a patient. I don't think I can show you any randomized trial that will be more powerful, more impactful in our business. So that left a mark on me. I've obviously saved this message, and that should tell you where we stand. Now, as far as the study goes, 5 times more chest pain with thermal RFA typically compared to cryotherapy, and this has been our experience both in clinical practice, and this is what's borne out by this very elegant study that we did with George Smallfield and a group of other people published a few years ago. I cannot end an esophageal cancer talk without talking about esophagectomy and what happens when endoscopy fails and so forth. So endoscopy is great, but it does fail in these scenarios. When you have a resection that is performed regardless of EMR or ESD, and you have poorly differentiated invasive cancer, that patient needs to go to the tumor board, and you need to invoke participation from your surgical and oncologic colleagues. Patients who have every imaginable modality thrown at them, including cryotherapy, and are still presenting with difficult esophageal disease, they need to go back to a multidisciplinary cohort where the best treatment can be envisaged for them. I think at some point, good clinicians and endoscopists know when they're not making progress, and most certainly the patients know when you're not making progress, so that needs to be kept in mind. A particular bullet point for the non-compliant patient, the patient who was not able to take acid suppression, doesn't show up for appointments as recommended. In certain cohorts, dysplasia and neoplasia will progress very fast, and you don't want to be on the wrong end of it. And of course, in cases where the esophageal anatomy doesn't allow safe and effective and meaningful therapy, those cases need to be brought to justice in a different manner. Take-home points. Endoscopic eradication therapy is highly effective for dysplastic Barrett's and early esophageal cancer. EMR and ESD have now come of age, even for Barrets and esophageal adenocarcinoma, we knew that they were highly established in squamous cell disease. They have both diagnostic and therapeutic value. Multiple endoscopic ablation therapies are available across the spectrum, from thermal to cryogenics. Liquid nitrogen spray cryotherapy has primary, secondary, and salvage applications, as I've highlighted. It is particularly effective in a highly enriched population of difficult-to-treat dysplasia and early esophageal neoplasia, and in select patients with T1B disease, and certainly we'll hear about its role in invasive cancer. This device and this application is highly well tolerated, it's safe, and it's effective, and it's been borne out by 10 to 15 years of high-volume clinical practice in this country. Established indications exist for referral for surgery, and please keep that in mind and for definitive chemoradiation for that matter. You don't want to mess with a disease that can flip on you over a period of time if not managed properly. I do believe firmly that multidisciplinary approaches to the management of this pathology, this disease, is really the key to success. And we hold our thoracic surgery colleagues and our oncology colleagues and everybody else involved, in our APPs, our nurses, our teams, our operational teams, very, very high regard, because this is a team sport. And what we show you here is an outcome of a number of people who don't get to come here and speak and present this data, but we're very grateful to our teams, and I know that Toufic shares the same sentiment. Thank you very much, and with that, I'll hand over the podium to Dr. Kachaamy.
Good morning, everyone. Thanks, Dr. Kaul, for this fantastic review. I'm honored to be talking to you today about a topic that's very dear to my heart. I want to take a second to recognize Dr. Alvin Zefas, who has probably trained the most gastroenterologists in the world, and who is the real father of cryotherapy. Thanks for being here. So I'm Toufic Kachaamy, an enterprise clinical leader at Cancer Treatment Centers of America and the director of gastroenterology in Phoenix. What I will be talking about today is liquid nitrogen spray cryotherapy's role in esophageal cancer beyond superficial cancer, after Dr. Kaul covered superficial cancer. It is very important to understand staging of esophageal cancer when you are going to take care of these patients. It's also very important, and I'm going to keep stressing this point as I go along, to speak the oncologist language. As Dr. Kaul said, this is a team sport, and our role is just being part of a large multidisciplinary team that starts with nurses, involves oncologists, surgeons, radiation oncologists, and radiologists. Early esophageal cancer starts in the mucosa, and when it gets to the muscularis propria, is when it starts becoming the muscularis mucosae is when it starts becoming invasive. You see on this slide the layers of the GI tract with the mucosa, the submucosa, and then the muscularis propria. T1B is when it crosses into the submucosal space, and once it does that, it gets access to the lymphatic tissue, and this is when the risk of lymph node metastasis becomes higher, and this is when endoscopic resection becomes less effective. As the cancer progresses and it invades through the wall, it becomes T3, or if it goes to the lymph nodes, it becomes locally advanced. And once it invades other organs, it becomes T4. If it invades other organs that cannot be resected, like the aorta, then it becomes T4B. Patients who are considered not surgical candidates or inoperable are the ones who are T4B or stage 4, once it spreads to distant metastases. These patients typically do not have surgery as part of their care. On presentation, esophageal cancer is not commonly localized. Most patients present either locally advanced and metastatic, and among the locally advanced, multiple patients progress to either metastatic or their performance status worsens with time, and they become non-surgical candidates. So the majority, there's a big number of patients that end up not having surgery, even the ones that start as surgical candidates. As Dr. Kaul said, this is a team sport. It's a complex disease that requires multidisciplinary approach, and it's important to understand the language that everyone speaks. I outlined here in general the management of this disease, but I want to stress that this is an oversimplification. So in general, for early disease, resection is done. If it's T1A or less, then endoscopic is appropriate. Once it becomes T1B or to T2 until it gets to the muscle but does not invade through the muscle, then surgery is appropriate. For some of these patients, they also get chemoradiation. But once it's localized, locally advanced, then patients get neoadjuvant treatment with chemotherapy and chemoradiation. And then if there's surgical candidates, then they get surgery. In the metastatic setting, the focus is on palliation. I want to familiarize everyone with the National Comprehensive Cancer Network. This is a not-for-profit alliance of 31 leading cancer centers in the United States that are devoted to patient care, research, and education. They set the standards for what we should be doing with these patients. So if you are going to engage in taking care of cancer patients, you need to be very familiar with the lingo used by the NCCN, and you need to be familiar with the NCCN guidelines, so to speak the oncologist language. In general, based on the guidelines and interpretation of the guidelines, this is where cryotherapy can potentially be used in patients with esophageal cancer. So in early disease, what Dr. Kaul covered, in general, when patients are non-resection candidate and for nodular disease where other ablation modalities can be less effective, cryotherapy is used. And then the next group of people would be post-chemoradiation. If the patients are non-stage 4 and non-surgical candidates, you either have residual Barrets afterwards that you can use cryotherapy for ablation, and I'll talk a little bit about the data, or if you've had complete clinical response and for eradication of Barrets, or if you have residual disease, you can use it to treat the residual disease. And the majority of patients who are stage 4 or non-operable, cryotherapy can be used for palliation. And I want to define palliation here because palliation means different things for different disciplines. The NCCN guidelines define palliation as easing the burden of disease without removing the cause. And the goal is to anticipate, prevent, and reduce suffering to the patient and the family, and to provide the best quality of life regardless of the stage of the disease. And they recommend using palliative modalities at the same time as the disease-modifying therapy. So when you talk to your oncologist, you need to be able to have this discussion, and often the oncologist will refer the patient at the end of their disease for palliation. You need to remind them that the guidelines for cancer treatment recommend palliation at the same time as disease-modifying therapy. And this is the area where we added to the literature, where we brought cryo early on in the disease, in the management. The oncologist typically will consider palliation as any treatment modality that does not provide cure. So they rarely focus on the quality of life, but for the gastroenterologist, palliation is about improving symptoms and improving quality of life. This is a slide from the NCCN guidelines, and you can see on the left, in unresectable, locally advanced, or locally recurrent or metastatic disease, they recommend systemic therapy if the patient has a good performance status and can tolerate systemic therapy, plus palliative and best supportive care. If the patient performance status is such that they cannot tolerate systemic therapy, then best supportive care is what's given. And in the past, this is where we used to get involved with cryotherapy when the patients were not on systemic therapy, but we have changed that paradigm. So what are some of the data on post-chemo radiation? This is a retrospective study on 14 patients, and I'd like to remind everyone that these patients are not very common. So when you see a number like 14, it's because this is not a very common scenario. So 14 patients who had dysplastic Barrets after chemoradiation for esophageal cancer. So they had a complete clinical response where no cancer was found on biopsy. These patients had a cryotherapy, and there was downstaging of dysplasia. So we brought them down from either high-grade or low-grade dysplasia to a lower dysplasia after just a mean of 1.5 sessions of cryotherapy. And there were no adverse events. The safety of cryotherapy is going to be a theme that is going to be recurrent in all of these studies that I'm going to mention. So what about if there is residual disease, post-chemo radiation? This is a multi-center study that had a mix of retrospective and prospectively collected data on 88 patients. 14 of them had a prior chemotherapy and 21 had prior radiation. These patients were staged as T1 and T2. Often after chemoradiation, our staging is not very accurate, so I want to take that with a little bit of a grain of salt. But this data is important, and Dr. Kaul mentioned some of this data. On 88 patients who received 359 cryo sessions, the dosing is 3 by 20 seconds every 4 to 6 weeks. And after a mean of 4.4 sessions per patient, they eradicated in T1 cancer in 66% of the times, and in T2 in 6% of the times. And again, there was no major adverse events, which is a recurrent theme in cryotherapy. This is a case of post-chemo radiation residual disease. So this is a 61-year-old gentleman who presented with dysphagia and weight loss in April of 2019. He was found to have an esophageal mass from 42 to 48 centimeters, and the biopsy was consistent with poorly differentiated adenocarcinoma. He was staged as T3, N1, M0. The patient received chemoradiation with weekly carboplatin and Taxol and 50.4 grays of radiation. And on follow-up at 6 weeks assessment, and we typically assess these patients at 6 to 8 weeks after treatment, he had a negative PET scan, and on the upper endoscopy there was residual ulceration you see on the top. And the biopsies were negative. There was no evidence of residual cancer. So he entered a surveillance program because he did not want surgery, and this is appropriate and an option. 8 months after treatment, his CT scan was still negative, but his upper endoscopy showed the nodularities you see at the bottom, and the biopsies were positive for recurrence of poorly differentiated adenocarcinoma. This patient declined surgery, and he had 2 cryotherapy sessions, 1 month apart, with a dose of 2 times 30 seconds, and this eradicated the residual cancer. And he's been followed up to now for 2 years, and with negative CT scans, PET scans, and upper endoscopy. And this was the last image on the right from his upper endoscopy with no residual disease and a nearly normal appearing esophagus. Shifting gears now to palliation, where the majority of patients will end up falling. We published in 2018 the largest retrospective study on 49 patients with 120 treatments, where the dosing was 3 by 20 or 3 by 30 seconds. And this was the first study that had patients who were on systemic therapy, and we kind of introduced that this treatment modality can be used in patients on systemic therapy, and this is where we changed the paradigm from getting the patient at the end when the oncologist has given up on them to treating them early in their disease. We found a 0.7 improvement in dysphagia score per cryo session, and a 5% adverse event rate, mostly minor. That study, however, was retrospective and had no quality of life assessment. This is a study that came from Mayo Rochester group, again retrospective on 56 patients who had an average of 3.6 cryo sessions. The complication rate was low, also less than 5% for major, 1 perforation and 2 bleeding. What they found is the majority of patients ended up not needing stenting before their passing. And even the ones who eventually required stenting, there was an average delay in stenting in over 1 year. All of us who have dealt with stenting know that stenting impact on quality of life is mixed. For some patients, the quality of life can worsen significantly with stenting. The rest of the data I'll show you is still in abstract form. This is a prospective study, so we're moving to higher quality data on patients who were not receiving any systemic therapy. 49 patients, 258 treatments, and 75% had history of chemo or radiation or both. And again, the dosing was 2 by 30 seconds or 3 by 30 seconds, and these were 6 weeks apart on average. And I'll discuss later why I think this is probably underdosing. But again, we see that the rate of adverse events was low, 7.4 percent, and again, this is higher quality data, with the majority of the adverse events being mild and the rest is moderate. What the study showed is 89% of patients had what we call a positive oncologic outcome. For the oncologist, progression-free survival, so if everything is stable, is a positive outcome. Sometimes gastroenterologists get disappointed when they see that they're not making progress. But remember, cancer keeps growing. So in the cancer world, if you keep things status quo, that's a positive outcome. So in this study, 72% maintained their swallowing and 17% improved when they were not receiving any other therapy. What you will see is also there was improvement in global health status. So we're starting to see quality of life data, which I think is very important. Improvement in social functioning, decreased dysphagia and eating problems. All of these were statistically significant. And the median survival was over a year. When you look in general at median survival of inoperable esophageal cancer, it's less than a year. So this group, after receiving a lot of therapies, when they were only getting cryotherapy, lived on average more than a year. I want to take a second to talk about dysphagia. We sometimes focus on the symptom. In reality, dysphagia is a big problem because almost anything we do in society happens around food. So when patients cannot eat, they stop going out with their friends to eat, which is where you see the decrease in social functioning or improvement if you can help with their swallowing. They stop sitting at the dining table with their family members. And dysphagia is really isolating. So while we focus on measuring a number, we have to keep in mind that when you're taking care of the patient, it's really their quality of life that matters and not a number. This is the study that we will be presenting tomorrow. So I'd like to invite you all to join us for this oral presentation. So I'll mention it briefly here. It is also still in abstract form on 48 patients, 153 procedures, and these were patients who were receiving systemic therapy or intended to receive systemic therapy, so early on in their disease. We showed improvement in quality of life, improvement in dysphagia, with no reflux and regurgitation in the majority of patients. And we're starting to understand how best to use cryotherapy because we compare 20 seconds to 30 seconds, we compare different dosing intervals, we found that more intensive treatment for the same number of cryo sessions give you a better outcome. So you get more bang for your buck if you put the cryotherapy sessions closer. Adverse events again are low with grade 3, which is what the oncologist terminology for adverse events, it's grading. Grade 3 or greater were seen only after 6 procedures. So in summary, cryo is safe and an effective option for esophageal cancer palliation. It's helpful for maintenance and improvement in dysphagia. It shows improvement in quality of life. The major adverse events seem to be less than 5%, which when you look at the NCCN guidelines, they highly emphasize the importance of choosing a safe modality when taking care of these patients' palliative treatment. So it is safe after radiation and during systemic therapy. It is not associated with reflux as opposed to stenting. In current practice, we are likely underdosing, especially in terms of interval. So as we understand better this treatment modality, I suspect that we will be doing a better job with these patients. I'm going to spend the last few minutes talking about how cryo works and how to use it in a clinical setting. Cryo has multiple mechanisms of injury, and this is why you see cell death and tumor shrinkage that is gradual. The first and immediate injury is with necrosis, and this has to do with freezing of the extracellular water and dehydration of the cells and freezing of intracellular water, breaking the organelles in cells. And this causes irreversible damage to the organelles and cell death. This happens better with rapid freezing, as I have there highlighted, and this has implications on how we do it technically. The second mode of death is with apoptosis. This is typically at the periphery where cryo freezing is slower and less deep. So the cell death is slower, it's more organized, and it's more due to mitochondrial damage, which is more sensitive to freezing. And that happens over time. And then you have microvascular thrombosis, which causes ischemia and a lot of cytokine release. And that cell death can be ongoing, and it can last for a couple weeks. The advantages of cryo is that tissue cooling, which includes the nerve ending, and this is why patients typically do not have a lot of discomfort after cryo. You know, like Dr. Kaul shared with us what the patient said about heat-based modality. They irritate the nerves and they cause more pain versus freezing numbs the nerves. It also allows selective treatment of the tumor without treating the surrounding tissue. Why is this important? Because things like radiation or PDT, photodynamic therapy, are not as selective in treatment, and this is why radiation has a limitation in the dose. You can't do radiation forever. It's not because of the tumor, it's because of the surrounding tissue that is damaged. While with cryotherapy, you don't have a limit on how much you treat, because you're basically killing a tumor that keeps growing. It has less scarring because the connective tissue is resistant to cryotherapy. So after regeneration, the connective tissue serves as a matrix for regeneration. And the muscle is very well vascularized. So surrounding tissue, if they get a little bit frozen, it's rarely a big deal because the underlying muscle does not freeze, so it's resistant to necrosis, and thus you do not have as high of a complication rate. So technical tips, of course, pre-procedure, we have to get the patient consents. We explain to them the benefits, the side effects, what to expect after the procedure. The type of anesthesia, in my opinion, doesn't matter, but education of your anesthesia colleague is important. If your scope is frozen, you cannot take the scope out immediately, so you have to let anesthesia know that if you have problems with sedation, you have to give us a little heads up and act early. If the patient is not being intubated, sometimes the cryogen will displace oxygen from the upper airways, so you can have mild hypoxemia. This is rarely important, but it's important to educate the anesthesiologist so they don't panic. Typically, when you're done spraying, the oxygen levels come back up. And staff is very important in safety of the procedure. The nurse monitors the abdomen, so it's important to have a consistent nurse who's familiar with the procedure who is going to help you. Intra-procedure, we measure the tumor. We dry the field as much as possible. One of the problems with the visualization is a non-dry field, which lets water and blood splash, and then you can have poor visualization. And then we place the wire, and you place the venting tube or the cryo decompression tube. And if we're unable to place the CDD tube, we do not perform cryo, because liquid nitrogen expands tremendously, and without aspirating the excess gas, you can cause a perforation. Intra-procedure, we advance the scope to the distal end. Sometimes you need to advance both the scope and the CDD tube as a unit, because of friction between them can prevent the scope from advancing. So I typically will hold both of them and advance them together, which allows me to get further down. I spray distal to proximal, 2 centimeters at a time. Again, you want rapid freezing. If you spray too big of an area with cancer, then your freezing becomes slow and your treatment is less effective. And then it's important to know what kind of appearance you need. You see on the left here the deep white freeze that you want before you start the timer. And then for cancer, the dosimetry is typically 30 seconds times 3. And then the thawing has to be passive. We don't allow active thawing. In frostbite, the recommended treatment is a rapid thawing of your fingers. So this, because you get less damage, so it's important to have the thawing as slow when you're trying to kill the cancer, and repetition. And I think probably the third treatment is probably the most effective because you get the fastest freeze. I'll show you how it's done for cancer. So as Dr. Kaul mentioned, this is a non-touch modality. You see the catheter coming out of the scope and the area being kind of conditioned for freezing. We move around. And if you dry your channel very well, your scope typically will not freeze. And then as I'm spraying here 2 centimeters of the tumor, when the area that is frozen is entirely frozen and white, then the timer starts, and we go 30 seconds after this, and we after thawing, we repeat it 3 times. We are happy now to take any questions, and I want to thank all of you again for coming here today, and I want to thank STARS for giving me the opportunity to educate on a topic that is very dear to my heart.
Great talk. In terms of high-grade dysplasia and early cancer, what is your typical dose and typical treatment interval, like time between successive treatments?
So the typical application, as I mentioned, is 30 seconds times 2 for flat Barrett's. That's dysplastic or post EMR or ESD, typically 6 weeks after the resection episode. So 30 seconds times 2. The interval for thaw is a minimum of 45 seconds. Sometimes it's less, sometimes it's more. But you need to rest the site between 2 applications for some time until the icing is gone. It's basically mostly endoscopic visual cues, but as originally laid out, you have to wait about 45 seconds minimum, and that's about the time it takes to for the thaw to emerge. In terms of between sessions, we typically have a 6 to 8 week time frame. It depends on the nature of the pathology, the degree of concern. Some patients do funny things along the course of treatment. Low grade turns out to have some high grade components. High grade starts to become nodular. So you know your patient best. And I think if I have concern that I need to really stay on top of a pathology, then I'll typically go no later than 6 weeks, sometimes under 6 weeks. But for low-grade dysplasia that's flat, and the endoscopy is not concerning, you could go out to 6 to 8 weeks, you could go out to 10 weeks in between. The timing between applications or sessions is really more critical for the cancer patient. You know, Toufic, you want to mention what your high-intensity protocol has become after years of experience with the safety of it?
Yeah, absolutely. So when we started doing cryotherapy, we would go 6 to 8 weeks. After we were not getting the results that we were hoping for, I went back and looked at animal data. And when you look at animal data, the maximum kill you get with cryotherapy is around 2 weeks. And then you get like a week of no growth, and then the cancer starts growing again. If you have a patient who's getting chemotherapy and cryotherapy, you can have a more sustained death before you see the cancer starting to grow again. So we've changed our practice to every 2 to 3 weeks. Typically, these patients are getting chemotherapy every 3 weeks. So you can bring them like a day or two before chemotherapy and perform your procedure. And we try to stack them up early in the course of the disease. So you'll see with my data tomorrow, for 3 cryo sessions, if you space them out, you get a lot less bang for your buck than if you put them every 2 to 3 weeks. So my practice has changed to, at the beginning of the diagnosis, once the patient starts systemic therapy, every 2 to 3 weeks, 3 sessions. And we used to manage these patients in the past from like a dysphagia, let's say, score. You bring them down from 3 to 2 or 3 or 2 to 1, and then wait for them to go to a higher dysphagia score. We try to bring them down to 1 or 0 and fluctuate them around that instead of give them a worse quality of life that we are maintaining. So earlier in the disease, you can get more bang for your buck. If they respond to chemotherapy, sometimes they don't need to come back because chemotherapy will halt the growth of the tumor.
So in terms of post-procedure discharge instruction, like how do you manage those patients after the procedure?
So this whole discussion with post-procedure management started with when both PDT but certainly RFA became more established. These patients had chest pain with thermal ablation, especially if you did long segment Barrett's ablation with the balloon. So that's where this whole paradigm came along in terms of pain management and such. The other aspect of that was the management of the oral intake post-procedure, which was soft diet and liquids and so forth. Now, with the advent of cryotherapy in the last more than a decade, it was the combined observation of most of the endoscopists who did both modalities that the patient recovered with significantly less chest pain and went home and stayed home with relatively less amount of discomfort, as was shown in our study, both at the immediate post-procedure time as well as 2 days out. So the requirement for pain medications as discharge is significantly lower. Our patients come from a faraway landscape, so we still have in our protocol the offering of going home with a liquid version of Tylenol and codeine, but the actual usage is much lower than it used to be in the RFA realm. But again, we don't measure that on a case-by-case basis, but we don't get that many phone calls. And you just saw a patient testimonial that I showed you. The one time I used a thermal ablation, he felt it. So I think, so we do offer the prescription. Many deny it, some take it. And secondly, we do encourage them to stay on a liquid diet the day off, especially if you've done a very aggressive treatment, and then soft diet for a week. That's just common sense, and I think that's something that most of us do. Some practices we've inquired over the years have not done that rigorously, but we've always done that, so I think you can't go wrong with that. A soft diet starting the second day is a reasonable compromise. So Toufic, what do you do with that?
So in our patient population, as you said, pain is usually not an issue. I mean, typically cancer patients are being taken care of by a pain specialist, so they often have the prescription for pain medications, but we don't get phone calls. Patients rarely have discomfort after this procedure. And in terms of diet recommendations, I let them drink liquids before they leave. I want to make sure they're feeling fine. And then I tell them, your next meal, you can advance to soft, and if you're feeling fine, then you can advance to whatever diet you feel comfortable with. Of course, if you start with someone who can swallow only liquids, they have to kind of test it, see where they are. And I typically tell them it's around 2 days where you're going to see the real improvement. So if they were on liquid diet before the procedure, I keep them on liquid diet until a couple days, and I say advance slowly as tolerated.
Any questions from the audience? Anybody else has any questions? So Toufic, when you talked about combining systemic therapy with cryoablation, how do you space them out? Is there you give 1 week between chemotherapy? Which goes first? How do you go about the mechanics of scheduling that and making sure that that you have a defined time interval and that you coordinate with the cancer treatment?
The retrospective study that we published in 2018 showed that the side effects did not matter as to when you've done it as in relation to systemic therapy. And when we originally started, we spaced it out 2 weeks, and then we slowly brought it down to, I've done cryotherapy on the same day as the chemotherapy. Billing-wise doesn't make a lot of sense, but for patients' convenience, sometimes we do it, because then most insurances won't pay you for 2 things, so you end up getting, giving the cryotherapy treatment for free. For patients who are in my center, I typically schedule it the day before, especially if they're traveling. So this way they come get the procedure, and I make sure they're fine before they get chemotherapy the day after. It's interesting when you try to capture adverse events in research. Chemotherapy has a lot of adverse events, so you end up with a lot of nausea and a lot of stuff that you don't see in patients who are not on chemotherapy. And the patients will tell you, like sometimes the chemotherapy will not start till after they're able to swallow better, so we'll do 1 or 2 sessions where patients feel great afterwards, and then when they start systemic therapy is when you start getting the phone calls. So for traveling patients, the short answer is we do it a day before, but I don't think it really matters. We do it more for convenience. And for patients who do not travel, whenever it works out for them and their caregiver to be available. I try to avoid doing it the week immediately after chemotherapy because they're typically not feeling great. And putting them through a procedure and anesthesia and things like that the week after is unless that's our only option, I try to avoid, mostly because they're not feeling great from chemotherapy. What is your practice?
Yeah, so I have spaced them out a little bit longer just because of some of the concern around chemo sensitization by cryo or cryo sensitization for chemo. There's just, but I think as you've shown, we continually try to push the envelope. And I think the takeaway from what you mentioned is that doing it the day before or a couple of days before the actual chemo event may be the best strategy because not only are they not feeling well, but there is a degree of pancytopenia or platelet dysfunction or thrombocytopenia that may be induced in some patients, depending on what chemotherapy they're on. So that's the new paradigm. I think we're going to see much more purchase from the combination of potentially definitive chemoradiation or non-definitive chemoradiation or just chemotherapy for stage 4 disease, and then combining that with cryotherapy. It remains to be it needs to be mentioned that this particular modality is really the only endoscopic palliation modality outside of stenting. And I know this is your favorite question, is for the person who says, well, I can just place an esophageal stent and be done with this patient, this individual, why do I need to go back every 2 or 3 weeks and apply cryotherapy? It's not like I don't have enough patients on my schedule, right? So how do you answer that question? How do you deflect the one-time? How do you respond to the one-time stenting, one and done phenomenon, and justify spray cryotherapy as opposed to that? So give us a little insight into that.
I want to thank you for asking this question. Yeah. Because I love to talk about this. Stenting one and done is rarely the case. I mean, patients come back with pain, the stent migrates, there's bleeding, so patients will end up getting scoped. And these patients are living a lot longer. When you look at the ASGE guidelines, they say stenting is preferred if the patient survival is less than 6 months. Why? Because then you don't have enough time to see the adverse events of stents. So this is the first layer of the answer to this question. The second layer is, and you'll see with our data tomorrow, stenting, the quality of life is a little bit tricky when you assess it. So when you look at dysphagia, stents show 90% improvement immediately within 24 hours. But patients cannot lie down, they have reflux, they have chest pain. We've all had patients who chose to go to hospice after stenting because their pain was intolerable. Even when you offer them to take out the stent, I had a patient a few weeks ago who said, you know what, I'm done. At my age, I'm done. That is not an outcome that you're proud of. That is not very common, but it does happen. And I rarely have that experience with cryotherapy where the patient says, I'm done with after a cryo session because they're not in discomfort. It's not one and done, in my opinion, with stents. It's one and done when you're not taking care of the patients in the long term. So sometimes in academic centers where patients come for a second opinion and they get a stent and they go away, it can feel like it's one and done. But if you're following these patients longitudinally, there are issues that happen with the stent in addition to the quality of life issues. And some patients, these are 82 years of age, lying down in a recliner for the rest of their life. It causes them back pain. We don't measure that in GI research. We don't look at the effect of stent on back pain, for example. That's only captured when you measure global quality of life. So all of these issues we have to talk about when we are talking about quality of life for the patient.
So I guess the takeaway from that is that something happens to these patients when they come in every 2, 3, 4 weeks for palliation of their esophageal cancer. Something happens to them that they live longer, they feel better, and they're not as miserable and or dejected as one of their peers who receives, let's say, a palliative stent and then enters the hospice program. And then when you check back the chart, 5 or 6 months later, they're no more. But something happens to these patients that they come in every so often, get the treatment, and they keep coming for years sometimes. And that's an effect you like to talk about as well. It's been talked about. We talked about it several years ago with Dr. Shaheen in the room, and some immunological, hormonal, psychological phenomenon is at play when patients receive any treatment. It does not just refer to cryotherapy, but any treatment for a dismal prognosis. Something happens to them. What's that something that's happening?
Again, I want to thank you for asking me this question.
Double payment.
Double payment. There's clear animal data, and we need to study this in humans, that cryotherapy, because of the way the cell death happens, the level of necrosis that you see with cryotherapy is extensive, but you do not see denaturing of the proteins. So you get a shower of immunogenic proteins that are tumor-specific after cryotherapy. And in animal data, this has been shown to induce the immunologic response. And in the oncology world, there's the tumor, and there's the tumor microenvironment. And the immunogenicity of the tumor and the immunogenicity of the tumor microenvironment determines the impact of immunotherapy, for example, which recently became standard of care for esophageal cancer. So the combination of tumor and tumor microenvironment determines the immune response to the tumor. And animal data clearly shows that when you do kill the tumor with cryotherapy, you get a more robust immune response than with other modalities such as radiation or heat-based therapy. Now, whether this happens in humans, there's very preliminary data that is coming out, some in pancreatic cancer, some in prostate cancer, that a similar phenomenon happens. But I think it is up to us to figure out how to maximize this phenomenon, and it's up to us to look in prospective data whether these patients who are living a year or two longer is it because of cryotherapy or there are some other factors. But when you look at almost all research published, the majority of it is retrospective. You see a prolonged survival in these patients that we are studying. Now, is it that they're getting more cryotherapy because they're living longer? Or more likely, they're living longer because we're altering the tumor microenvironment. That needs to be seen in human studies. Yeah.
I want to thank you both very much for speaking on this topic today. This microphone's too tall for me. There we go. We really appreciate your time, and thank you very much.
Thanks a lot.